Okay, you can go ahead,
Okay,
Dr. Luffy.
okay. Thank you very much.
Who's sharing the slide? Please, can you
Um,
reshare the slide? Okay, you can go ahead.
okay. Good morning, my teachers and my senior colleagues. I'm Dr. Olufi. I will be talking on question 9 of WACP October 2023 um, exams. Next slide, please. And the question goes, does a male student develop a pruritic rash after wearing his friend's boxers? A picture of the rash is shown below. Next slide, please. Okay, this is the slide. Next slide. A, the questions are describe the picture shown, and then B, what is the diagnosis? C, list 3 medications used for treatment and mechanism of action of the medications. Then D, what are the health issues to be addressed and how would you educate this patient? And then E, list 5 complications. Okay. So one, okay, so question, okay, the A question describe the picture shown. So it's a widespread bright red macronodular pustular lesions or satellite pustules involving the penis, scrotum, groins, and upper thighs. Then the diagnosis is Candida intertrigo. Next slide, please. Then it said list 3 medications used for treatment and mechanism of action. The medications are topical clotrimazole, topical nystatin, and topical ketoconazole. Next slide. Mechanism of action. The azoles, example of them are clotrimazole and ketoconazole. They are actually broad spectrum antibiotics. Then he beat the fungal cytochrome P450 enzyme alpha dimethylase, which is responsible for converting lanosterol to ergosterol, which is the main sterol in fungal cell membrane. It also inhibits mitochondrial cytochrome oxidase, leading to accumulation of peroxidase that cause autodigestion of the fungus. Okay, it also causes alteration of the DNA and RNA metabolism. Then the nystatin, which is a pollen, is a selective fungicidal drug. It disrupts fungal cell membrane by binding to ergosterol, which alters the permeability of the cell membrane, leading to leakage of intracellular ions and macromolecules, and ultimately leading to cell death. Now say, okay, what are the health issues to be addressed, and how would you educate this patient? The health issues are one, direct examination of the skin specimen to demonstrate fungal presence, and then also isolation of the fungus and its identification. Yeah. Then the advice would be to avoid sharing clothes with friends, as the disease he got was from wearing his friend's boxers. Next question. The complications are one, disseminated candidiasis, candida granuloma, paronychia, and onychia will lead to severe itching and secondary bacterial infection. Okay. So I would like to talk on candida using the following outline: introduction, classification, down to references. Next slide, please. So candida belongs to the family of the Saccharomycetes. It's actually an Ascomycota in phylum, and there are about 200 species, and about 20 associated with pathology in humans and animals. Okay, so it's actually the asexual form is an anomorph, and then we have the telomorphs, which are of several and general demonstrated to be of different species. Then the telomorph genera, we have the Clavispora, the Babromyces, Isachenkia, and then the Cluveromyces, we have the Pichia, and then the Yerowia. Next slide. Yes, the habitat is actually, it's important for us to know that it's an ubiquitous yeast found on many plants. It's normal flora of the GI tract of animals and mucocutaneous membrane of humans. It presents in all areas of human GI tract. The common species of the GI tract, we have the Candida albicans, tropicalis, we have the parapsilosis, and then the glabrata. Next slide, please. So the major pathogenic species are listed below: the Candida albicans, glabrata, the cruci, the Cuphea, and East telomorph, and then down to the Lusitania and East telomorph, which is Clavispora, Lusitania. Next slide. So the morphology, yeah, we have the polymorphic yeast, which is actual example of them, which is the yeast cells, hyphae, and the pseudo hyphae are produced by the polymorph yeast. They have the ability to assume various forms, which may be related to the pathogenicity. The yeast forms are actually 10 to 12 micrograms in diameter. They are gram positive. They grow overnight on most bacteria and fungal media. The pseudo hyphae may be formed from budding yeast cells that remain attached to each other. Then the spores may be formed on the pseudo mycelium, which is called the chlamydospores, and can be used to identify different species of Candida. Next slide. This is just a slide showing the morphology of Candida albicans. Next slide, please. Then this also different morphologies of the different species that we have of Candida albicans. Next slide. The epidemiology of Candida albicans is a human commensal. The major reservoir is the GI tract. It can invade into bloodstream from GI tract after damaging the gastrointestinal mucosa. Sources of infection could be endogenous, which could be primarily hematogenous spread to various organs. It can also be exogenous, which involves introduction into the body through medical devices or catheters. It's important in the development of deep-seated and systemic infections. Next slide. Their transmission is from person to person, though not predominant. In case of oral thrush, from mother with vaginal candidiasis to newborn, and also during birth. Then sexual transmission can be from females with vaginitis to their sexual partners. Risk factors could be prolonged therapy with broad-spectrum antibiotics. Okay, clinical significance. Yes, it can cause disease called candidiasis, and the clinical manifestation may be acute, subacute, chronic, or episodic. Can cause various forms of infection ranging from superficial manifestation involving skin, nails, and mucosal surfaces to deep-seated infection involving various internal organs to disseminated disease. It can be divided into two large groups, which is mucocutaneous candidiasis and a deep-seated candidiasis. Okay. So the mucocutaneous forms could be cutaneous, nail infection, and the mucosa infection. Let's move, please. So, like the case that was brought out in the West African exam, yeah, which our diagnosis is the Candida intertrigo, which is the most common form. Organisms colonize skin folds, particularly in moist and macerated sites such as the axilla, groin, the inter and submammillary folds, and the umbilicus. Form erythematous lesions with vesicles, which is elevation of skin with clear fluid, and pustules, which is elevation of skin and purulent fluid, in combination with pruritus. Next slide, please. We have the erosio interdigitalis, which is the skin folds between the fingers become macerated and itchy, associated with excessive exposure to moisture, and then it's common in dishwashers, bartenders, fruit cannery workers. Then we have the diaper candidiasis, which involves infants wearing nappies. Rashes seen in perineal area and on buttocks. Infection may be secondary to pre-existing inflammatory condition. Next slide, please. Then we have the chronic mucocutaneous candidiasis, relatively rare condition, most severe clinical form of superficial candidiasis, which is caused by Candida albicans. It's characterized by the presence of persistent lesions with high rates of recurrence, starting in early childhood and persisting throughout the individual's lifetime. Lesions at various skin sites, so not limited to skin fold. Then it can also present as warty lesions, which is termed as Candida granuloma. Next slide, please. Then we have the nail infection, which is paronychia or onychia, and the agent is Candida albicans or parapsilosis or the Candida bullimondi. It's characterized by prominent swelling, redness, pain, and then we have the paronychia, which is infection of nail folds, a fold of skin supporting nail at its base. Then we have the onychia, which is infection of nails. Affected nails become discolored, eroded, brittled, detached from nail bed, and it's painful, as the image. Okay. Then we have the mucosa infection, which can be oral candidiasis, vaginal candidiasis. We can see it on the pictures above, showing the involvement of the oral mucosa by the Candida albicans, evidenced by thrush, those whitish patches that we can see at the roof of the mouth and also at the base of the tongue. All right, please. Next slide. So oral candidiasis, most frequent, the major agent is Candida albicans.
Dr. Luffy.
Yes, ma'am.
Good morning. I must thank you for, I sorry I had to interrupt you. Thank you so much. We really appreciate you. Just that we have to answer this question again. You're not answering it. You're not answering the question. So let's not spend so much time on the wrong question when we have not answered the question. So please, sorry for interrupting, but because we're recording, so we have to answer the right question so that we know we're done with this question. The answer to this question is actually scabies. So I allowed you to speak, and since you're already in an overview of fungal infection, let's not dwell too much on it. So please, can you go back to the question? Let somebody help so that you will answer the question again as scabies question, please. Thank you so much.
Okay, thank you, ma'am. Thank you. Wow. Okay. A male student, are you with me, please?
We are with you, sir. We can hear you.
Okay, so a male student developed a pruritic rash after wearing his friend's boxers, and a picture of the rash is shown below.
Yeah, so Dr. Abimbola Olaita wants to speak, so just speak.
Yes, sir. Good morning, sir.
Just leave.
From the rash that is shown, I think, like I put in the chat, I think it's scabies. Number one, from the question, he took a friend's boxer. That means they are living together, maybe in a hostel, and that kind of parasitic infection is common there. Then from the look of the rash, is erythematous and papula, and we have been told that is itchy, and that is one characteristic of scabies, intense pruritus that's even worse in the night. Then if we look closely, maybe we can see burrows and excoriation, and it can also be secondarily infected by bacteria. That's why I think it is scabies.
Thank you so much, Dr. Light. And we've already agreed on that. So we've already told him to go back and represent it as scabies.
Okay.
So let him represent it as scabies. Dr. Obi, sorry for taking back, but since we need to get the right thing there, I know it's something you can do.
Yes,
so since you know it's scabies, just answer the question like scabies, then the class will contribute, and we all make such mistake. No one knows it all. We all contribute and learn, and so thank you once again.
Thank you so much, man. Thank you.
Okay, well, We'll go to the next presenter.
Hello? Hello?
Yes.
Hello?
Yeah, we can hear
Can
you,
you
sir.
hear me? Yeah,
Yes, sir,
all
we can
right.
hear you.
I want to thank the presenter for the presentation. That's practically the reason why we're asking all of you to be presenting, so that it's okay to make mistakes here and get corrected. But it's not okay when you make them in the exams. You won't get corrected. You just fail the station. So, but here you get corrected, you learn, you know why you ask questions, and you get better at it. So well done. All right. Bye.
So can you unshare the slides so that the next presenter can share?
No, he should answer the question. He can answer it.
Okay,
Let
I was
him
thinking,
answer
okay,
the
he should answer
question.
the question. Oh, okay,
Yes, so that
okay. I
no,
was
we're
thinking he
recording
was
this
to
thing so that we
present it.
quickly know that we're done with that particular
Okay,
question. He can answer it. He can,
okay,
if he
all
can,
right, sir.
class is a discussion, the class will help him out. And there are a lot of dermatologists in the call. They'll help him out. It's not a
Okay.
problem at all.
Okay. So I can start from the diagnosis. So the diagnosis is scabies. Okay.
You
And I
start
say
with description. Your description with
okay.
one of the lesion.
Okay.
You know, most stations are manned by specialists. So you describe it again. Dr. Adiola, please, you help me correct him, please. Dr. Adiola, ma, she's a fellow, she's a dermatologist. I don't want to be the only one speaking in the class.
Okay, ma. Good morning, ma.
So thank you so much, sis. Thank you. So please go ahead so that we'll correct you so that whoever is listening will know that this is how to describe lesions for dermatologists, because the dermatologist will manage the station. And sometimes you will use, just put the person off.
Okay. Thank you, ma'am. So the lesions are widespread and bright red macronodular lesions involving the penis, the scrotum, and then the upper thigh.
Erythematous.
Erythematous.
Please be taking corrections. That's the essence.
Okay, sir. Okay. So there are widespread erythematous macronodular lesions or macropapullar lesions involving the penis, the scrotum, and the upper thighs.
Yeah, thank you so much to the presenter. Let me quickly correct. I'll just correct as you go on so that we don't use too much time. So there are multiple. It's not widespread, means all over the body. They just showed us the genital area here.
Okay.
So there are multiple. It's no more than one, and they are discrete. They are standing alone. So multiple discrete erythematous papules on the genital area. If you want to be more specific, on the penile shaft, the scrotum, and the upper thighs.
Okay. Thank you, ma'am.
So you can go on.
Then big question, what is the diagnosis? Diagnosis is scabies. Then list 3 medications used for treatment and mechanism of action of the medications. The 3 medications are, we have the malata, we have we have the permethrin, then 0.5% melatonin, and then I think steroid can be used too.
We don't typically use steroid. It's going to mask the itching and make the lesions worse.
Okay. I only know of permethrin and 0.5% melatonin.
Thank you so much. You really tried. So 5% permethrin, usually applied from downwards. It's usually given is usually applied overnight over 8 hours. The first day, then you repeat it 7 days after. The second one we use, you can use 1% lindane, malathion. You can also use 5% sulfur ointment.
Okay, ma'am.
Benzylbenzoate can be used, or however, is very, very peppery and corrosive. Yeah, so it's not typically used regularly again, but it can be used as well. Okay. Then you can also use ivermectin.
Yes, yes.
So ivermectin can be used at the dose of 200 micrograms per kg. You give a start dose and you repeat it a week after. Okay. Then the mechanism of action for most of the medications, they are neurotoxic to the mites. It is caused by Sarcopsis scabies mites. Sarcopsis scabies va-omin, that's the one that affects humans. And the treatments are neurotoxic to the mites, the Sarcopsis scabies mite. So you can go on with the option D, with the question D.
Okay, thank you, ma'am. Then what are the health issues to be addressed, and how would you educate these patients? Okay, I think the health issues to be addressed here are one, that scabies can be, it can be transmitted, and then if not properly treated in this patient, it can become Norwegian scabies, and then I also want to do contact tracing, probably the sexual partners, or if he has a sexual partner, so as to 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 curb it, and then sorry, yes, ma'am.
All right. Thank you so much. You really tried. You really done well. So basically, it can affect the quality of life of affected individuals. The pruritus can be very, very, very intense. If you understand Yoruba, the Yoruba name is Komobo Stop. Like you literally will eat anywhere and everywhere. So the major health challenge is the distressing level of the pruritus and the fact that it can actually spread rapidly among close contacts those that are affected. And if it's not properly and promptly diagnosed and treated, it can persist for months, even for years, if it's not properly treated. And the Norwegian scabies is usually seen in those that are immunocompromised. So if there's a contact with anybody that is immunocompromised, the person can actually develop the Norwegian scabies, but they don't typically itch like people that are that have proper that their immune system are working properly. Okay.
Yes, ma'am.
Yeah. So the major thing is one of the neglected tropical diseases, and the pruritus is quite very, very intense. So it affects the quality of life of affected individuals. It can cause depression. It can cause even suicidal thoughts because they don't know why they are itching. And itching is typically at night. They've gone around their daily activities. They come home to rest, and they keep itching up to the point that they can't sleep. So depression, suicidal ideations for some of them, and some of them can lead to other medical illness, like there could be superimposed bacterial infection, and that can lead to post streptococcal glomerulonephritis. It can lead to infective endocarditis if it is not properly managed. Sorry, can you hear me?
Yes, ma'am.
So the last question.
Okay, ma'am. Then how would you educate this patient? Yes, I will educate the patient by telling him that the disease he got was as a result of sharing his friend's boxers, and that the disease can be contacted through sharing of items with somebody that has this disease, and that he should avoid sharing clothes or items with people.
Yes, you are right. We can take the last question.
Okay, then list 5 complications. One, can lead to severe itching, can lead to chronic depression, and then secondary bacterial infection, can lead to Norwegian scabies if the patient is immunocompromised, and then and then can lead to sepsis, leading to infective endocarditis and multiple organ dysfunction.
Okay, yeah, you already mentioned most of them. So persistent itching, insomnia, because they won't be able to sleep. Then the secondary bacterial infections I mentioned earlier. Then there could be outbreaks in the community as well.
Okay.
It's within closely related set of people, like the IDP camps, for instance. There could be an outbreak, and in the community, they can actually cause an outbreak within the community.
Okay.
So Norwegian scabies is not typically a complication, is a type of scabies. Is a type of scabies infection or infestation rather.
Okay, ma'am. Okay. Thank you so much.
Thank you, Dr. Adiola. Thank you so much for coming in. Dr. Olufi, thank you. I must comment you. You didn't give up. You attempted, even with all that happened. That's a very wonderful spirit, a fighting spirit. You didn't let it get to you and just give up at that. So thank you. Keep it up. Keep it up. Thank you, Dr. Adiola, once again for coming in to answer the question with him. I think we're done with that question. We'll see her 2 times, so we can take the next question. I don't know if the participants have comments. Let's keep it brief so we can answer at least 2 questions today.
Hello, ma.
So
Yes, ma.
the next. Can you share your slide? The next person.
All right. So hello everyone. Thank you, Dr. Luke, for soldering on. Well done. I was thinking a part of the complication, also the things that some of those health issues that were mentioned could be part of the complications, the depression and the other ones, especially like depression. It could be mentioned as part of the complications too. Okay. Right.
Okay. Thank you, sir.
Dr. Olufi, worthy of note is glomerulonephritis. So please, don't in exam just say multiple organ failure. List the organs specifically. List them. You understand? So instead of saying multiple organ failure, start listing the organs that would be affected. But overall, it was a fair attempt. Who is the next presenter, please?
Thank you.
Good morning, everyone. Good morning, Dr. Victor. Good morning. Hello.
Yes,
We can hear you. Go ahead, please.
Okay, good morning, Chief Remigos. So well done to the presenter. So I just want to let us know that even though he answered it wrongly, there's one thing I want us to take it. Go back, download the slide for Tinea, cruris and put it side by side and compare so that you can see the difference, especially on the skin lesions, so that when it appears in the exams, you'll be able to answer correctly. And they can, as well, these exams, change it to bring a picture of Tinea cruris so that to confuse people. So I think it's better you go and look at it side by side. Don't delete that your presentation. People can read it, but put the picture of Tinea cruris so that at least if it comes in exams, you answer it along that side. If it is Tinea, if it is scabies, you answer it along that side. Because of course, sometimes it might be confusing, but that papules and erythematous lesions you see, which you will not see that papules and that buros, especially in Tinea cruris. Thank you.
Yeah, you are very correct. Thank you.
Dr. Olalekan. Can anybody hear me?
Yes, we can hear you.
Dr. Olalekan.
Olaleko was not in the class. I just admitted him now. So
Okay. Good morning, ma. Okay, please, I don't know if you can hear me.
Yeah, we can hear you.
hear him now.
Okay, thank you so much. Okay. Good morning, teachers and all our colleagues. So I'll be taking question 2 of national recall. Please, can you move to the next slide, please? Okay, the question is a 45-year-old ICU nurse who developed fever, dry cough, breathlessness, and sore throat of 5 days. She's known to have chronic obstructive pulmonary disease. The blood pressure was 148/98. Temperature was 39.6 degrees centigrade. Then the oxygen saturation, 74%. Chest X-ray is said to be normal. The laboratory results showed leukopenia, thrombocytopenia, and elevated fibrin degradation products. The first question is list 3 differential diagnoses. The second one is what is the most important investigation? Then C, how will you manage this patient? Please, next slide. Okay, my first differential is COVID-19 infection, SARS-CoV-2. And then other differential, the second differential is other viral respiratory tract infection, like adenovirus, respiratory syncytial virus, influenza virus, and so on. Then thirdly, bacterial pneumonia. Next slide, please. Okay, the reason why I'm thinking of SARS-CoV infection, COVID-19, because of the symptoms of dry cough, fever, breathlessness, and then sore throat of 5 days, and with signs of hypoxemia, SpO2 said to be 74, with then the fever, pyrexia of 39.6, and then with the identifiable risk factors, which is patient said to be a known patient with COPD, then also the possible risk factor of hypertension, although the blood pressure was only given once. It wasn't stated whether the patient is a non-hypertensive, but blood pressure was 148/90 millimeter mercury. The chest X-ray is said to be normal, though this is expected in the early or patient with mild diseases. And then the laboratory test of leukopenia and thrombocytopenia and the elevated fibrin degradation product. Next slide, please. Okay, so what is the most important investigation? The most important investigation is actually the nucleic acid amplification test, which is actually a a viral diagnostic test for COVID-19, and it helps to detect the genetic material, majorly the RNA virus. And then with specimen, which is taken from the upper or lower respiratory tract infection, can actually be tested in this patient. Next slide, please. Okay, so other investigations, which I just added this, that since the chest X-ray was said to be normal, chest X-ray could actually show some features as listed above. Then the chest computerized tomographic abnormalities in COVID-19 are said to be bilateral, then with peripheral distribution, and then usually involve the lower lobes. Next slide, please. Okay, so how will you manage this patient? Actually, is a multidisciplinary approach involving an infectious disease specialist, intensivist, pulmonologist, laboratory physician, and pharmacist. It actually require hospital admission, hospital management setting, because the index patient actually had severe disease of COVID-19 with the dyspnea, breathlessness, then the hypoxemia as a result of the oxygen saturation of 74%. So the patient, I will admit the patient to the intensive care unit. Patient will need to be commenced on oxygen therapy, and that is because of the hypoxemia. Then oxygen therapy could actually start as with low flow oxygen, and if there is not significant improvement, I may need to increase to a high flow oxygen or a non-invasive ventilation. And if there is no remarkable improvement, the patient may need to be ventilated. Then I also like to give some medication, pharmacotherapy, the remdesivir, low dose dexamethasone, and also some immunologic like the baricitinib and tocilizumab. Then other things I would also like to give is to give antipyretics. Consider that this patient has a temperature of 39.6. Then thrombocytopenia, I would also like to correct that by giving platelet concentrate. Then I would also like to hydrate the patient because of the breathlessness. Patient will actually I'll be losing a lot of fluid. I'll be increasing insensible water loss in this patient. But I have to be very cautious so that to prevent patient having non-cardiogenic pulmonary edema. And we also like to treat the underlying conditions, like in this patient, COPD. Then also if the patient's blood pressure is actually going up, getting higher, we also want to give antihypertensive. Then I also like to investigate for other risk factors, which probably may not be listed in this patient. The only thing that was just said was the COPD and then the possibility of hypertension in this patient. I also like to look out for any other risk factors and also address them accordingly. Then also to investigate for any complications, whether the early or the late. Then also patient will also benefit from vaccination when patient is stable. Next slide, please. Now, the index patient actually had a severe disease, and the reason is because these are the characteristics of severe disease. Patient with dyspnea, hypoxemia, with oxygen saturation less than or equal to 94% at room here. Then the need for oxygenation and or ventilatory support. This patient actually requires oxygenation because of the oxygen saturation, which was 74%. Then with patient also have tachypnea, respiratory distress, and then when you have more than 50% involvement of the lung parenchyma on chest imaging, preferably the chest computerized tomography scan. Next slide, please. Okay, so I'd just like to talk briefly on COVID-19. Okay, COVID-19 is actually a novel coronary virus, which was first detected in the city in China, that's Wuhan, and it has rapidly spread to all countries all over the world. Next slide, please. Okay, in February 2020, the World Health Organization actually designated the disease COVID-19. That was when it was designated as COVID-19 infection. And then it was said to be similar to SARS-CoV-2, and with a previous name of 2019 and novel coronavirus. Next slide, please. So it has continued to infect several thousands of people with preventable morbidity and mortality across the world. And there has been development of vaccines and treatment which has helped to reduce hospitalization and then with disease severity and mortality. But the virus has continued to evolve with variable infectivity. The median incubation period is said to be 5.2 days, but most patients are said to develop symptoms within the period of 11.5 to 15.5 days. Next slide, please. Okay, there are variants of SARS-CoV-2. We have the alpha variant, the beta variant, delta variant, gamma variant, and the Omicron. Next slide, please. Okay, so talking about the virology, coronaviruses are envelope positive stranded RNA virus, and the full genome sequencing actually indicate that coronavirus causes COVID-19 is actually a beta coronavirus, and is said to be in the subgenus of the severe acute respiratory syndrome virus. That's the SARS virus. Next slide, please. Okay, this is just the picture showing the virology with some glycoproteins. We have the S protein, which is a spike, the membrane protein, the nucleocapsid, and then the envelope protein. Next slide, please. Okay, these proteins are actually needed for the attachment to the ACE receptor, as well as the inoculation of the virus into the host cells. Next slide, please. Okay, when talking about the pathophysiology, it actually falls under two things. One is the viral invasion, and then the host response. The mode of transmission is actually from person to person, mainly through respiratory droplets. But fecal-oral route is also said to be possible. And then the presence of this virus has been confirmed in the sputum, pharyngeal swabs, and then feces. Vertical transmission has also been reported in those with positive naropharyngeal swab for the virus. Next slide, please. So talking about the viral invasion, now the SARS-CoV-2 virus actually attached to the host cells through the spike protein, that's the S, attaching to the angiotensin converting enzyme 2, which is actually the entry receptor for SARS-CoV-2. And this angiotensin converting enzyme 2 is said to be expressed in various other organs in the body, including the small intestine, the kidneys, the heart, the thyroid gland, testes, adipose tissue. And this may be directly, this affectation of those organs is as a result of the viremia, which is present in patients infected with the virus. Next slide, please. Now, okay, I've talked about this. Now, after the attachment of the S protein to the AC2 receptor, now there's a particular protease which is called the transmembrane serine protease 2, which actually helps to cleave the S protein, and then the nucleocapsid protein is actually deposited into the cytoplasm of the host cell, and through that the RNA, genetic makeup now begins replication, and then translation, replication in the host cells, and later on now causes release of these viruses that have been multiplied. Next slide, please. Okay, this is just a pictorial diagram showing what I just explained briefly. The viral attachment, then to the activation, then the viral uptake, then the fusion of the virus, the membrane of the virus, as well as the host membrane, the host cell membrane, and then we have viral replication. Then for subsequently, the virus is actually released to infect other host cells through the same mechanism. Next slide, please. Okay, so the second pathophysiological process is actually the host response. Now, the first line of the physiological defense against it is said to be a well-coordinated, localized immune response, but over time, there's actually hyperfunctioning of the immune response. Now, what COVID virus infection actually does is that it induces cell death and injury, especially to the cells that have been infected, and it does this through pyroptosis as well as necroptosis. And then there are several chemoattractants which actually release, which actually helps also in release of some cytokines, some pro-inflammatory cytokines, causing the inflammatory reaction. Next slide, please. Next slide, please. Next slide. Next slide, please. Okay, this is just a picture showing the physiological process in the host immune. Now, when the first one is actually the physiological host response. When the virus enters, there's early infection. Then the next one, which is the 2, there's the host is able to take care. But when there is increase in the replication and multiplication of the viruses, as a result of the increase in the cytokines being produced, the interleukin-6, interleukin-10, interleukin-2, and several other ones, there's hyperinflammation, which is the hyperinflammatory phase. And when this continues unabated, it actually will progress to multi-organ dysfunction, considering that those other organs I listed earlier, which actually has the receptor for the ACE2 receptor. Next slide, please. Next slide. Next slide, please. Time. Okay, so some of the clinical presentation, like in our index patient, actually had cough, headache, but these 3, cough, myalgia, headache, are said to be the most prominent symptoms in patients that actually have COVID-19 infection. But in our index patient, actually had dry cough, had fever, sore throat. These are the other presentations that could also be present, are the diarrhea, anosmia, ageusia, fatigue, confusion. Can we move to the next slide, please? Okay, so there could be some dermatological presentation, in which case patient could have maculopapular rash, mobiliform rash, urticaria rash, and then sometimes some people could actually have what we call the COVID toes, which is actually a reddish purple nodules on the distal digits, similar in appearance to penile. Next slide. This is a pictorial diagram showing the COVID toes. Next slide, please. Okay, so other clinical findings could be patient could have conjunctivitis. Some of them could actually, because those that have increased risk of severe disease are the elderly. So there could be decline in the health function, could have delirium, which is actually been reported in elderly people. Then in female, they could have menstrual irregularities. Next slide, please. Now, there are some risk factors which are associated with severe disease. Like in our patient now, we can categorize that patient actually has a severe disease. But other risk factors, or established risk factors rather, associated with severe disease include age. People greater than 65 to greater than 65 years, patient with diabetes, asthma, chronic lung disease, fibrosis. Next slide, please. Okay, so patient with disabilities, cancer, cerebrovascular disease, then obesity or overweight would also be a risk factor. Next slide, please. Okay, so these are some of the risk factors for physical inactivity, pregnancy, smoking, sickle cell disease, thalassemia, tuberculosis. Next slide, please. Okay, now the next, these are possible risk factors in which evidence is actually mixed, which we have alpha-1 antitrypsin deficiency, bronchopulmonary dysplasia, hepatitis B, hepatitis C infection, hypertension. Next slide, please. Next slide, please. Next slide. Okay, talking about the investigation, the diagnostic test is actually the nucleic acid amplification test, which I mentioned earlier. Next slide, which is actually said to be diagnostic. Now, the commonest one which is being used is actually the reverse transcription polymerase chain reaction. The others could actually be used as well. Next slide. Then other investigation that could be done, as seen in the patient with full blood count, as lymphopenia, thrombocytopenia. Then you can check for the kidney function, liver function test. All those organs could actually be affected, are actually based on the clinical presentation. It will actually warrant the next supportive investigation that will need to be done. Next slide, please. Then antigen tests could actually also be done. And these actually, especially for self-testing, and it's said to have a reported sensitivity of 84.1% with a specificity of about 98.5%. And it actually uses enzyme-linked immunosorbent assay. Next slide, please. So for imaging, for chest radiograph, yeah, the chest X-ray finding could actually be normal, especially in the early or in the mild disease. And some of those common findings actually include consolidation, ground glass opacities, and it's said to have been reported that Some could have a spontaneous pneumothorax. Next slide, please. Okay, this is just a pictorial that I'm showing the chest radiograph with the peripheral distribution, and then the bilateral involvement, and also the lower lobes, which is being affected in them. Next slide, please. Okay, next slide, please. Okay, this is just a chest, high resolution chest CT scan, which actually showing peripheral distribution of the lesion, which is the ground glass opacity with the lower lobe involvement. Next slide, please. Okay, next slide, please. Okay, we're talking about the management. Actually, the management has actually evolved over the years since the coronavirus has been identified. And this actually, commencement of treatment early actually helps to reduce mortality in them, and also help to prevent early or late complications. Next slide, please. Okay, so part of the management actually involved defining the severity of the disease in this patient. So we have patient could have mild disease, moderate disease, or severe disease as indicated. Please, next slide. Next slide. Okay, so management actually depends on whether they have clinical or laboratory risk factors, as well as if they have severe disease. Most times, the reason for hospitalization is actually if patient actually requires oxygen therapy or no requirement of oxygen therapy. Next slide, please. So for those that do not require oxygen therapy and they have risk factors for severe disease and require hospitalization, remdesivir is actually recommended. And this helps to actually improve time to recovery in some patients. But they said at this stage, one does not need a low dose dexamethasone, because at this stage, low dose dexamethasone can actually is associated with a worse outcome in them. Next slide, please. Now, for those that require oxygen therapy could range from the low flow oxygen, high flow oxygen, or mechanical ventilation. And this will also determine the pharmacotherapy that will be needed in them. Next slide, please. So for those that require low flow supplemental oxygen, one could give low dose dexamethasone or remdesivir, which is said to be recommended. But if there's need to increase the oxygen from low flow oxygen to high flow, then that means there will be need to add the immunologics in patients. Next slide, please. Now, there's a term called escalating oxygen requirement, which is defined as a rapid increase of 6 liters per minute or more of oxygen within 24 hours, or probably a patient that requires at least 10 liters per minute of oxygen or more. Now, and in these categories of patients, studies from the available trials have shown that when we had baricitinib or tocilizumab to dexamethasone, it actually helps to reduce mortality in these categories of patients. Next slide, please. Now, for those that require high flow oxygen, low dose dexamethasone actually recommended in them. And for those who are within the 24-hour to 48 hours of ICU admission, or within 96 hours of ICU admission, then one can actually add baricitinib or tocilizumab to the low dose dexamethasone. Next slide, please. Okay, for those that require mechanical ventilation. So for those that require
mechanical... Try to round up, yeah.
Okay, oh yes, I'll round up. I just have 1 or 2 more slides. Okay, so for those that require mechanical ventilation, low dose dexamethasone is actually recommended in them. In such patients, we're not expected to start remdesivir. But for those that are on remdesivir, they can be continued, whereby low dose dexamethasone could actually be added. Next slide, please. Next slide. Next slide. Now, on outpatient basis, for those that don't require hospital admission, one can actually consider this option: no therapy. Then we can give nirmatrelvir with ritonavir in combination, then remdesivir or convalescent plasma. Next slide, please. Okay, these are some of the early complications: respiratory failure, acute kidney injury, acute liver injury, acute cardiac injury. Next slide, please. For late complications, it could range from pulmonary fibrosis, Guillain-Barré syndrome, and also a terminology called long COVID. Next slide, please. So for long COVID, it's said to occur in patients with history of a probable or confirmed SARS-CoV-2 infection. And this symptom is said to persist for more than 3 months after the onset of COVID-19 infection. And sometimes it could actually last more than at least 2 months. And it's said that these symptoms cannot be explained by an alternative diagnosis in that. Next slide, please. So for the prognosis, the time to recovery from COVID-19 is actually variable. And this depends on the risk factors, the age, the vaccination status of the patient, and also some pre-existing comorbidities in the patient. Next slide, please. Okay, so these are some of the preventive measures: wearing of face masks, avoiding of crowds, then regular use of hand sanitizer, hand washing. Then it's also recommended that someone should have get vaccinated. Next slide, please. Next slide, please. Next slide, please. Okay, these are some of the vaccine. We have the messenger RNA vaccine. Then in conclusion, do not use COVID-19 therapy for individuals who are asymptomatic. And then it's very important one should identify risk factor. Like in our patient, that patient actually has COPD and the possibility of hypertension. Then treatment with COVID-19 specific therapies can actually be repeated with each new episode of infection. And then those with severe disease needs to be admitted and then also given oxygen therapy. Thank you. Thank you so much for the presentation.
Dr. Atta. Is there any comments, any questions, please?
Yes, ma'am. I have a comment. Thank you very much, Dr. Olalekan, for that excellent presentation. My comment regarding the differential diagnosis. I think mentioning the viruses is not the right way to go about it. Rather, the number one differential is COVID-19 pneumonia or SARS-CoV-2 pneumonia, not just saying COVID-19 infection. Infection can be anywhere. So it should be COVID-19 pneumonia or SARS-CoV-2 pneumonia. Another differential is hospital-acquired pneumonia, the fact that this patient is an ICU nurse. Also, community-acquired pneumonia can be a differential, as well as acute exacerbation of COPD, being that she has an underlying COPD. Then other upper respiratory tract infections can come in. Then with regards to oxygen therapy, because this patient has an underlying COPD, you can't give her high flow oxygen. Rather, you give oxygen at low concentration of about 24 to 28%, targeting at least 94%. So this is my little contribution. Thank you for the excellent presentation.
Thank you, Dr. Fatima. Dr. Fatima, a consultant now. Let the participants speak. Let the
My, because
participants.
there is no much time, that's why I just chipped in.
Okay. No problem. Thank you so much. Dr. Tanimu, I don't know if you have anything to say. We need to close the class.
No, Dr. Fatima have said everything. Thank you very much. It's a nice presentation.
Thank you. Thank you. So, Dr. Olaleko, thank you so much for your wonderful presentation. It was quite lucid. Thank you so much. The other presenter, Dr. Luffy, thank you, Dr. Atta. Thank you for anchoring. I appreciate you all. Then our participants, our teachers, thank you for coming to class. I don't know if our teachers have more comments. If Remicus Shimanza